Tim, thank you for the introduction and thank you for the invitation. In the abstract book for this meeting, in the introduction section, it suggests that this talk is going to provide the answer for what is the best cardioplegia solution for our patients. And I'll argue that I won't be providing one answer because there are many questions, and the questions are determined by the patients, and in some ways, each individual patient. But what I will do is to talk about the evidence and its limitations, and then talk about some ideas on how we can take things forward. So cardioplegia is essential for cardiac surgery for most procedures, and it's our primary mechanism, along with hypothermia, of protecting the heart during ischemia reperfusion. It arrests the heart and allows us to operate inside it with a still and bloodless field. But I'll argue that perception is that cardioplegia works, the cardioplegia solution has worked if the heart stops when we put the cardioplegia in, that it restarts when we take the clamp off, and the patient goes home. But how well does it protect the heart? Does it really protect it? And which of the solutions available to us is the best for which patient? So to understand myocardial protection, you have to understand ischemic tolerance. And this is the period in which the substrate and oxygen supply can be interrupted without causing reversible injury. And the work by Buckberg and others, as shown in the graph, has shown that electromechanical arrest significantly reduces oxygen uptake. And on the left-hand side of the graph, it shows the white bar of the beating heart and the fibrillating heart have significantly higher oxygen consumption and energy requirements than the arrested heart. And this is true across hypothermia, such that there's a stepwise reduction in energy requirements the colder you get, such that on the far right dark bar, the cooled, empty and arrested heart only uses about 3.5% of the energy of baseline. However, this is not zero. Therefore, during ischemia, there's an ongoing requirement. And this basal energy requirement is for maintaining cellular homeostasis and other normal cellular processes. And cardioplegia extends, but does not replace this tolerance, such that the longer the period of ischemia, the worse the outcomes, because the greater the injury. And that's such that any significant period of ischemia can result in myocardial injury. And this graph is taken from a paper on remote ischemic preconditioning as an adjunct to cardioplegia. And this paper showed a significant reduction in troponin release, as shown on the graph between the red preconditioning and the blue control area under the curve. And this difference was associated with an improved 30-day survival. But the important part is not the difference between the curves, it's the fact that there is a red curve. Even in the best group, there was still significant injury during surgery. So how can we evaluate the evidence that's available to judge which solution is best? Well, randomized controlled trials are the gold standard for evaluating healthcare interventions. They have a protocol that's predefined, it's rigorously tested, and through this, there's minimization of bias that could influence the results. But in order for the results to be meaningful, these trials need to be run, designed and conducted to the highest standards. And from our point of view, there are two phases of clinical trial that are most relevant. There's phase 2 and phase 3. These phase 2 trials look at efficacy and safety, i.e., can it be done? And phase 3 trials that look at clinical effectiveness, which look at can this work in the real world. And it's these phase 3 late trials that influence guidelines and can potentially change our practice. So looking at clinical trials in adults, a meta-analysis compared blood versus crystalloid cardioplegia in over 5,000 patients from the Toronto group. And they found a significant reduction in low cardiac output following surgery and a reduction in the release of CKMB. However, you'll note that the analysis for these two aspects was only conducted in about 20% of the patients that were in the whole meta-analysis because they were not listed as outcomes in those studies. In larger groups of patients, they found no difference in myocardial infarction or in death, but they concluded that there was support for using blood cardioplegia over crystalloid. But there were lots of limitations. The heterogeneity of the data across these trials, as well as comparing blood and crystalloid, there were many other factors that were involved, such as the composition, the temperature, the dose, the interval, and the delivery. And there was also marked variation in the outcome measures reported. As mentioned, the CKMB was only in 7 trials, and therefore this limited their ability to meta-analyze the data. And most of these trials are small, with surrogate endpoints. Only 2 trials had more than 1,000 patients. First was Martin, which looked at continuous warm blood cardioplegia versus intermittent cold crystalloid. Well, that's 3 different comparators already. In addition, there was normothermia in the warm cardioplegia group and hypothermia in the cold group, yet another difference. And this may have influenced the fact that the trial was stopped early. So in 1,000 patients undergoing coronary bypass grafting, they found no difference in any of their clinical outpoints. Another study from Overu in Oslo compared cold blood with cold crystalloid in over 1,400 patients and found no difference in any of the clinical outcome measures. And more recent systematic reviews have not revealed any larger trials. When looking specifically at warm versus cold cardioplegia, again, a meta-analysis of over 5,000 patients showed no difference in clinical events, in death, myocardial infarction, low cardiac output syndrome, or balloon pump use. But they did show an increase in cardiac index and a reduction in biomarker of injury release. But the meta-analysis didn't describe how many studies this was in, so we can only assume that it was a small proportion. And again, the problem was the heterogeneity of the techniques and the differences in the outcome measures reported. The largest of the trials included was the Warm Heart trial, which in 1,700 patients undergoing CABG found no difference in clinical outcomes, but a reduction in CKMB and low output syndrome. In children, the results are even more sparse, such that there's never been a phase 3 trial of cardioplegia in children. In a meta-analysis looking at trials comparing blood with crystalloid, there were only 5 trials to compare, and whilst they found a difference in lactate, there was no difference in any of the other clinical variables assessed. So we've looked more broadly at in a systematic review at all cardioplegia trials in children, looking in all languages and all different types of cardioplegia. And we identified 24 trials with only 1,500 patients, and the largest of which contained 138, so all small trials. But the problem was that there was such variability in the techniques and variability in the outcome measures reported that it wasn't feasible to do any more meta-analysis other than that was already done by FAN. So that shows us 2 real main problems with the literature in cardioplegia. Firstly is the variability in the techniques. All these trials look at different things, different types of cardioplegia, different blood dilutions, different temperatures, different doses, different intervals. And that doesn't take into account any of the patient factors. The second problem is the outcome measures. So whilst mortality is a well-defined endpoint, the time of reporting the outcomes is variable. In myocardial injury after surgery, there's no clear and, I think, useful definition of perioperative myocardial infarction. The assays that are used are highly variable, different troponin assays, high sensitivity, CKMB, and even newer markers like fatty acid binding protein. But even if you settle on one troponin, which metric is the best to look at? A whole variety have been reported, including area under the curve, peak, at a single time point. And is there a difference between the different populations that we're looking at as to which one of these markers would be best? Unfortunately, at the moment, we don't know. When assessing ventricular function, the definition of low cardiac output syndrome between different trials is different, and therefore it makes it difficult to combine them. In addition, how that relates to long-term ventricular function and how that's assessed is variable. Similar to troponin, the inotrope use is reported in a number of different ways, whether that's total dose, peak dose, duration, or inotrope score. And what's the relevance of clinical outcome measures such as length of stay? So this heterogeneity in the data and lack of firm evidence has led to quite a variation in practice. In adults, this study from a little while ago in 2004 in the UK, looking at adult surgeons performing coronary artery bypass grafting, showed that 84% of surgeons use cardioplegia, with the remainder using cross-clamp fibrillation, a technique that's been known for 30 years to have significantly higher energy requirements and therefore potential for injury during surgery. Of those using cardioplegia at that time, 83% used blood, but there was a mixture between warm and cold blood. In children, a more recent survey by the Congenital Heart Surgeons Society looked at use of cardioplegia and stratified it by the age of the patient. Again, practice was variable between surgeons. Whilst 88% used blood cardioplegia, the most commonly used solution was Del Nido in 38%, and the next most common was customized solutions that were made according to their own recipe, presumably with very little evidence. There's clear variation in the amount of blood that's combined for blood cardioplegia, from the 1 to 4 in del nido up to 60 plus in microplegia. Most of the solutions were cold, less than 10 degrees, but when they compared across the different age groups, across the different solutions, there were longer intervals between dosing, as you may expect, between del nido and custodial HDK versus other cardioplegia solutions, as shown in the graph on the right at the top. In the lower graph, where they compared across different age groups, they found that actually there was a pretty standard technique used by surgeons across the age range, with little variation according to the patient. And that suggests to me that the strategy was primarily determined by what the surgeon wanted to do, rather than what was, by evidence, shown best for the patient. Again, in another survey of international practice, there was marked variation. Whilst depolarizing agents were most common, as shown in blue on the graph, del nido was rarely used outside North America, but custodial was quite common across Europe and Central America. And this suggests that perhaps geography is more influential on what solution is used for the patient, rather than the patient themselves. So how can we take this forward? We've got limited evidence, and the outcome measures that we use to assess it are variable. So I suggest 5 areas in which we can improve to improve the care of the patient. The first of these is through phase 3 randomized controlled trials. Not only do we not know which solution is best for the average patient, we don't know which is best for a neonate, and that's unlikely to be the same as what's best for an elderly patient. What we don't really need are yet more small phase 2 studies looking at these already established techniques, comparing surrogate outcome measures. We need large, multi-center trials which will recruit a large number of patients with clinically relevant outcome measures that will only be achieved through collaboration, whether this collaboration between centers in countries or internationally. And again, there's no point in putting the patients and the investment into such studies if they're not designed, conducted, and reported to the highest standards. And in other work that we've done, we've shown in a paper about to come out in the European Journal that actually there's very poor quality of trials within pediatric cardiac surgery in particular. So in the UK and Ireland, we're setting up a network across all 12 centres to conduct clinical trials, particularly in paediatrics. And this is the problem that we're facing. So this graph shows clinical trials on PubMed listed with cardioplegia either in the title or the abstract. And you can see that the main body of clinical trials was conducted during the mid to late 90s, and that subsequently there's been a marked decline. And if you were to look at this, you would think that this was actually a problem that was solved, that there was no need for more clinical trials because we knew the answer. And 2017 is on course to be the lowest number of trials in cardioplegia since the early 80s. But as I proposed at the beginning, injury is still occurring to the heart, and we don't have an answer. Secondly is the development of core outcome sets. So core outcomes that are agreed for either for adults or for children and reported in all trials. These should be clinically important, they should be standardized, and they should be validated. At the moment, we can measure troponin, but we don't know which is the best troponin to measure, and we don't know the best way to measure it. And how do these correlate with late outcome? How should we evaluate early and late ventricular function? Because it's the late ventricular function linked to survival and quality of life, which is most important. But by using these defined core outcome sets, we can then pull data from clinical trials into a meta-analysis, something that's proven difficult so far. And this falls under an initiative by the COMET group, which is looking across medicine to try and standardize for particular disease conditions the way that the core outcome sets are agreed and reported. If we don't fully understand the problem that we're up against, then it's going to prove difficult to find a solution. Ischemic reperfusion injury, knowledge has grown a lot over the last few years, but this has not been reflected by new cardioplegia solutions. 15 years ago, few people had heard of the mitochondrial permeability transition pore, but it's since become established that this is the final common pathway through which cell death occurs in ischemia and in other conditions. And therefore, this should be a potential therapeutic target, but no cardioplegia solution or no other protective technique takes that into account. Myocardial metabolism. It's been shown recently that one of the main drivers of reperfusion injury is the accumulation of succinate during the period of ischemia, both through anapleursis and also through reversal of part of the Krebs cycle. That therefore, on reperfusion, when oxygen is restored, leads to a burst of reaction oxygen species, and this is one of the main causes of injury. But there are no therapies in clinical practice that take this into account. And it's only through collaboration with basic scientists that we can start moving this research to the bedside. Fourth is innovation. I think that the data I presented shows that injury still occurs and that the current solutions, whilst we don't know which is best, are not the whole answer. We need newer, better techniques for preserving the myocardium. We need to build on the knowledge that we've established so far. For example, the immature myocardium is different to the adult, both in terms of substrate utilization, insulin sensitivity, calcium handling, antioxidant, etc. But we still use similar or the same solution for adult patients as we do with children. What we need is a systematic approach, moving from preclinical studies through to early phase trials and on to late phase studies. And what's the role of other adjuncts to cardioplegia? There were 2 papers published last year in the New England Journal of Medicine looking at remote ischemic preconditioning, 2 large trials, the ERICA trial and the RIP Heart trial, which both recruited over 2,000 patients, and they were both negative. But it was near the end of those trials that it emerged that propofol is actually a major blocker of the remote ischemic preconditioning pathway, and therefore it was unsurprising that both were negative. But 5,000 people were recruited to those trials at a lot of expense, when it could have been predicted a couple of years later that they would both fail. And finally, personalized medicine. We know that each of our patients is different, not just the adult to the neonate, but patient A to patient B. So why do we use one-size-fits-all therapy to protect the heart? Why not produce tailor-made solutions designed around the patient and their myocardial metabolism? And this could be done through genomic analysis to identify a panel of factors that, in the genome that can influence the way in which patients tolerate ischemia reperfusion and the way in which we could protect the heart better during surgery. And you might think that this is pie-in-the-sky, way in the future technology. But it's already happening in patients with cancer. Across a variety of cancers, the genome of both the patient and the tumour are taken into account in determining which systemic therapy is best. So in conclusion, cardioplegia has been vital to the development of cardiac surgery and made it possible for over 60 years. But there's limited evidence, despite that long period of time, for the solutions that we currently use. There's a lack of phase 3 clinical trials, particularly in children, and a lack of core outcome sets by which to assess the different solutions. And I put to you that myocardial protection is not a problem solved, despite the radical decline in the number of trials reported recently. We know that myocardial injury occurs routinely in the operating room, and there's need for innovation to address this. And finally, in order to really improve patient care, we should move into the genomics era and treat the patient as an individual. Thank you.
Well, Nigel, thank you very much for that great overview and insightful and thoughtful comments at the end. Any questions? Whilst people just gather their thoughts, if I can just open up one. There's clearly been a massive amount of work done already, and we haven't got an answer. And you've alluded to some of the reasons why we may not have an answer. And I agree that we need to go to personalised, tailored care. But then we're never going to find an answer, are we? Because once we start personalising the care, can we still do a randomised controlled trial? Because there's no standard any longer.
2 things. First of all, the reason that the evidence so far has been lacking has partly been related to the trials and partly been related to the variability and the options available. As you say, going forward, if you were to assess a genomic mechanism for evaluating cardioplegia, it would make the trials more difficult. However, the evaluation of the markers in order to determine which were the most important to vary between different solutions could be included as part of a trial. And it may be worth hitching a genomic aspect to a trial in order to be able to assess the variability in outcomes according to different genomic markers.
Okay. A question?
There are suggestions to add propofol into the cardioplegia or for example, esmolol from another group. What are your thoughts about these sort of innovative suggestions?
They're indeed innovative and worth pursuing. There is limited evidence currently clinically for both of those and no late trials. So they're part of the innovation, to understand more about the process of ischemia reperfusion and how different solutions may protect the heart better. There is basic science evidence for both of those two, but it hasn't progressed so far significantly beyond small phase 2 trials.
Thank you.
Walter Wildevuur, I have one question. Shouldn't we maybe customize cardioplegia to the surgeon and not to the patient?
Spoken like a true surgeon.
So in some ways that's happening already because the surgeon primarily chooses the cardioplegia. But as we showed from the survey, there's very little difference across their age groups for changing the solution within the surgeon. So at the moment it is based upon the surgeon. I would argue that there are surgical factors, including the period of ischemia, but the main factors that influence the ischemia reperfusion is the patient.
I don't think so, because if you have a good surgeon, he protects the heart by his surgery much more than the other surgeon. So maybe you need other protective techniques.
Mm-hmm. There's no excuse for bad surgery, and if there's solutions that better protect the heart, then potentially those bad or slower or whatever surgeons could be better accommodated through improving myocardial protection overall.
I'd just like to make one comment about, in the States, del nido cardioplegia is almost universal in pediatrics now, and even in the adult group, you can see more and more people using del nido in adults, and without a lot of evidence. So I really commend you on your whole process that you developed here. Excellent.
But the original thought process behind del nido cardioplegia was that the immature myocardium was different.
Right, exactly.
So now translating that and using it into adults is taking us back to where we've been rather than taking things forward.
Thank you.
But if it's better, it's better.
We don't really know. Thank you.
Thanks.